session on clinical clues in pediatric neurology. Pediatric neurology is a subject which every examinee going to the exam almost always fears about, and we have such an accomplished speaker expert, Dr. ANOOP VERMA of the national repute, who is means a very special talent in the sense that he has been developing those visual clues for some since those times when you don't have this video camera and a mobile, which is now so easy. So from those times he is having treasure of those visuals and videos, which shows his passion and about this subject. And I thank our honorable chairperson, Dr. RASHMI Kumar ma'am. Welcome, ma'am. Thank you so much for joining as a chairperson. And she's the president of the Academy of Pediatrics Neurology Chapter UP and secretary of the Academy of Pediatrics Neurology Chapter, Dr. ANOOP Kumar. He's another chairperson. Welcome, Dr. ANOOP. I think you all the three persons are the key who was spreading the flag of the pediatric neurology for first time ever in Uttar Pradesh. And UP PG teaching activity also means trying to put the PG this neurology subject as three, four cases of the neurology and topics of neurology. We had a topic of examination of nervous system in 2 editions last time. So this is a subject which postgraduates need a repeated and there's no better person than Dr. ANOOP VERMA and Dr. RASHMI Kumar and Dr. ANOOP Kumar. So welcome you all, and just I'll begin a brief introduction of the chairpersons, and then I'll hand over the sessions to the chairpersons. Welcome Dr. Sanjay Niranjan sir, who is going to take over very soon. He's the president-elect. Next month he's going to be taken as a new president of the UPIAP.
Thank you and welcome. Thank you and welcome all to the session.
And I welcome all the postgraduates and the faculties and all those delegates who have joined here and more to join. So Arun ji, आप मुझे मेरा host co-host बना दीजिए मुझे. You have taken away my rights to share. Yes, thank you.
Okay, so
first of all, I introduce Dr. RASHMI Kumar ma'am. She's a former head of the department and professor at King George Medical University, Lucknow. She's the director, Child Health Community Empowerment Lab, consultant pediatric neurologist, Lucknow, and she's a graduate and postgraduate alumni of AIMS Delhi and member of the INCLEN and India CLEN and past president Association of Child Neurology 2014 to 16. Special interest in pediatric neurology, infectious diseases, especially Japanese encephalitis, dengue, and TBM, typhus, and clinical epidemiology. She has held several portfolios to her credit, of important ones: President Lucknow branch, 30 research publications, 13 funded research projects, ICMR HB Dingley Research Award, ICMR BK Oration Award, Fellowship in Infectious Diseases, University of Connecticut, and Herman Friedman Traveling Fellowship and Award, Fellowship National Academy of Science India 2011, and Fellow Indian National Academy of Medical Sciences and University Research Award. So many awards, such a distinguished teacher and a pride of UP faculty. Welcome you, ma'am, and thank you so much for sparing your time and being here and sharing your knowledge with the PGs. Thank you, ma'am.
Okay. Then, thank you, Dr. Shalab. And it's really a pleasure to be chairing this session.
Thank you, ma'am. Dr. ANOOP Kumar.
Okay. Dr. ANOOP.
Dr. ANOOP Kumar. He's a budding pediatric neurologist from UP. He has been very much hardworking and is establishing the pediatric neurology chapter. As ma'am, I forgot to tell, is the president of the Academy of Pediatrics UP Neurology Chapter, and Dr. ANOOP Kumar is the secretary of the Academy of Pediatrics Neurology Chapter UP, and both of them are carrying forward the subject of neurology in Uttar Pradesh especially, and going to help so many events they have held also and going to organize. So Dr. ANOOP Kumar is the Director General Genrext Neurocare Aligarh, consultant of Columbia Asia Hospital, Ghaziabad, Secretary of the Academy of Pediatric Neurology, and Executive Board Member of the Academy of Pediatric Neurology India 2020-22, and member of the Future Leaders of the International Child Neurology Association, as Secretary of the IOP, Aligarh, Uttar Pradesh, and specialist in clinical neurophysiology, epilepsy, autism, and ADHD, and ketogenic diet therapy. So I request, I hand over the session to Dr. ANOOP Kumar and RASHMI ma'am. So I request Dr. ANOOP Kumar to please introduce Dr. ANOOP Verma formally, and then I'll have a request with Dr. RASHMI ma'am to please give her vision, what way she's going to spread this chapter of pediatric neurology in UP. So Dr. ANOOP.
Thank you, Dr. Shalabh Kumar sir. I first of all congratulate Dr. Shalabh Kumar sir, academic coordinator of Academy of Pediatrics UP, for organizing such a elucidative lectures in the form of clinical clues in pediatric neurology. For this, we are having one of the best teacher across India, Dr. AOP Verma sir, who is the director of Swapnil Nursing Home, Raipur, Chhattisgarh. His areas of interest are pediatric neurology and clinical genetics. He has been editor-in-chief of PAI textbook pediatrics, editor-in-chief first and second edition of IAP textbook of pediatric neurology. He is the author of Spotters in Pediatrics and Pediatric Secrets. He has been editor of IAP textbook of pediatric radiology. He has got the award of Doctor of the Year by National IMA in 2015, FIAP in 2003, FIAMS and FCGP in 2007, and he is the honorary fellow of Academy of Pediatric Neurology. So he is the National Executive Board member of IAP in 2000, 2005, 2012, 2014, 2015. He has been National Vice President of IAP in 2005. He has been the National Chairperson Academy of Pediatric Neurology in 2008 to 2012. He has been the Central Working Committee member of Central IMA 2007, 2009, 2011, and 2012. He has been the IAP Constitution Committee member in 2019, 2020. And along with that, he is the national coordinator of our National Academy of Pediatric Neurology, Neurology chapter of Central IAP. So welcome, sir, and kindly give your thoughtful narration. Over to Dr.
Shrivastava. Yes. So I just to repeat that I'm really, I'm really honored and very pleased to be part of this session. And I know it's going to be very exciting, very interesting topic. The topic itself is so interesting. Clinical clues in pediatric neurology. So with that, I won't waste any more time. I'll give over the mic to, or hand over to Dr. ANOOP Verma with the request to share his presentation, and welcome to all the participants. Okay.
I am not seeing the presentation.
सर Zoom को minimize कर दीजिए अपने इसको Zoom को.
Zoom तो पूरा ही minimize है. आप लोगों को दिख रहा है क्या?
सर Zoom लिखा हुआ दिखाई दे रहा है.
Can't see your slides. No slides.
अच्छा. Okay.
इसमें लिखा है you are screen sharing, so maybe.
अच्छा एक मिनट.
Welcome and regards, Dr. R.S. Sethi, sir. Dr. Ajay Shrivastava is there.
Just a minute. Presentation open किया था वो पूरा.
Share screen.
नहीं.
Okay, great.
दिख रहा है क्या?
Yes.
Is it okay?
Yes.
Am I audible?
Yes, absolutely okay.
Okay, thank you. First of all, I would like to convey my very sincere thanks to UP Academy of Pediatrics, especially Dr. Shalab Agrawal, who is the state academic coordinator. And I am aware that President-elect of UP IAP, Dr. Sanjay Niranjan, is also on the stage. And welcome. Dr. Ajay Shrivastava, who is the Secretary of UP IAP, I also welcome him. And Dr. Alka Agarwal, I am not seeing who is the state president. And definitely with all, Dr. Sethi sir is here gracing the occasion. With due respect and regards to our chairperson, especially Dr. RASHMI ma'am, who is the senior most neurologist of the region, and first state president of UP Academy of Neurology, along with Dr. ANOOP KUMAR, who is a vibrant secretary of and who has taken the bid to organize the forthcoming national neurology conference at Agra, and all the PGs. Thank you for honoring me to give the very prestigious stage of Uttar Pradesh to share my experience on clinical clues in neurology. You are all seeing these videos. They are all giving you some message that, look, I am present, kindly pick it up. If and we all know that what our eyes knows, what our brain knows, our eyes used to see. And I will start with a quote of Sir William Osler, that learn to see, learn to hear, learn to feel, and learn to smell. And know that by practice alone, you can become an expert. And medicine is learned by the bedside and not in the classroom. This is a very strong message for the PGs that try to use your tenure of 2 to 3 years in the department, examining the patient, being the try to use all your important instinct, maybe hearing, maybe seeing, maybe feeling, maybe smell, all should be used in your clinical apart from your text teaching and all. This is a very, very important area which one should inculcate all throughout the year, all throughout the hour, days, weeks in the department, because department is the real treasure. When you come out and be in the practice, you will hardly going to see such a lot of huge cases which you have seen in your teaching program. So it is a very, very important message that try to use your each hour and days in the department examining the patient. Basically, this is a sort of interactive session, and I will going to teach on clinical clues and with brief clinical presentation, and we will not talk on the treatment part. Now, just concentrate on this video, what a patient is exhibiting. Just concentrate that what type of movement the patient is exhibiting. To brief you that he is an 8-year-old and he's had a history of sore throat few months back, and he has had a history of joint pains. There was no history of drug. The family history was almost normal. On examination, asystolic murmur was there, and hung up knee jerk and hypotonia was there. So the clinical clues, if you have been asked to pick up, what can be you can describe in this video. So this is a patient who is exhibiting a random movement, flowing in nature, and you can see there is a marked voluntary movement, more proximal than distal. It's restless, and this is just see the face. This is restless. So definitely we are dealing with a case which phenomenology fits in with the chorea. Now, the investigation was performed, and it was seen that ESR raised, ASO was 370, and ANA negative, ECG was normal, echo normal. So what can be your diagnosis? Listening to the clinical history and examination and investigation, definitely phenomenology wise, we are dealing with a case of chorea. Investigation, adding and extracting something from the investigation, we are definitely, that is a sort of a post-streptococcal condition, that is the rheumatic chorea. Whenever any patient who is in front of you exhibiting abnormal movement, just try to focus on the head of the patient, then over the trunk, and then over the upper extremities. So by doing this, you are going to pick up that the movement is central or peripheral. And we know that you can also see that the movement who is exhibiting is a proximal one, or he is exhibiting a distal sort of movement. And therefore, the phenomenology of abnormal movements, maybe a chorea, maybe a tetosis, maybe dystonia, can be picked up phenomenologically. So there is no more difficult art to acquire than the art of observation. All in your daily rounds, you are taking in the, just develop this skill, which is a very, very important skill. And the skill should be such that even the patient is exhibiting abnormal movement on the very temporal side, even you are not gazing or gazing this patient, you can pick up that, yes, he is exhibiting this type of movement, and you can pick it up very easily. So this type of approach should be there in dealing with this. And we all know that abnormal movements, if it is planning the range of movement and speed of the movement, you can see that dystonia, chorea, tetosis, they all overlap each other. And therefore, it is a very basic rule in any abnormal movement that what you are seeing here is the athetosis, chorea, and bellismus. These are all in the same wavelength. You can see the athetosis is a small breathing movement, chorea being in middle, and bellismus is the very violent flinging movement that this. So this is the clinical clues. What we are seeing here is the overlap is often the rule rather than exception in movement disorder. This is a very, very important message, that there you will not see a very pure case of chorea. There must be a chorea tetosis or choreobellismus like that. So this is another important sign. And we all know that this abnormal movement, especially in chorea, there are two sorts of movement. One is a voluntary movement and one is involuntary movement. And in an attempt to perform a voluntary movement, suddenly involuntary movement comes and makes the thing vulnerable. And these are all known as a parakinesias. And this also makes this patient restless. So they are not able to perform the, even if they unbutton the clothes can be difficult. So these are the classical signs which we can make the involuntary movement separate from the voluntary movement, what is known as the classical sign. So this is the patient. If you have asked the patient to straight forward, and you will see that there is a hyperextension at the metacarpophalangeal joint, and there is a frequent extension and the flexion at the wrist, what is known as the, this is the piano sign, as if he is playing the piano. If you ask the patient to stick out the tongue, so he's not able to sustain the protrusion, and which is all due to the motor impersistence. This is the lizard tongue or the darting tongue. If you ask the patient to make the hold the arm up vertically upward, he will not. The hypotonic limb jerks and there is a hyperpronation. And this is what is known as the touchdown sign or the pronated sign. If you ask the patient to hold your finger, you can just feel that he is milking your finger. This is again due to the motor impersistence. He cannot sustain the pressure on your thumb. This is the classical, another classical sign. This is known as the milkmaid grip. So all these signs, what you are seeing here is the chorea specific and not the etiolospecific. What does it mean? That chorea, which is produced by the drug, a chorea which is due to the lupus, any cause of it, they will exhibit all these signs. So it is not an etiology specific. So in this patient, if you what are the close differential in this patient, and I will show you. So here is a patient who is having a rheumatic chorea. Here is a patient who is a lupus one. He is a APS patient. So what clinically they will present in the form of chorea, but how you are going to differentiate is the rheumatic chorea. We know that there is a history. History is classical, systolic murmur, ASO-ABD. Where is a lupus? We have a clinical phenomenon. Multi-system disorder is there in lupus. AN is positive, and APS is there is a family history of epilepsy. Could be a transverse myelitis. Anticardiolobin antibodies can be seen, and beta-2 microglobin antibodies can be seen in APS. So you can differentiate by history, by examination. Otherwise, phenomenology, if you see all the three patients can have a similar phenomenology. Now, here is again, now these are the three videos. You have to comment on these videos. The video number 1, what you are seeing here is the patient is not stable. He is fidgety. He's exhibiting more abnormal movement, which in phenomenology is favoring chorea. On the second video, what you are saying, he has been asked to see laterally. Instead of moving the eyeball laterally, his whole of the head is moving, what is known as the oculomotor apraxia. Third video, you can see the ataxia or truncal ataxia can be noticed. So chorea, oculomotor apraxia, and truncal ataxia. And furthermore, if you examine the patient's eye, you can see the leash of conjunctival vessel, which is also known as the telangiectasia. You can see the more in details. So this was a case of ataxia, telangiectasia, and this is another area where the chorea presentation is seen in less than 5 years of age, one of the important cause. So treatment, and we will not go to treatment, but we should remember that instead of this, chorea is present more than 350 years. His phenomenology has not been changed, but definitely the understanding of the disease, understanding of the etiology, but still we are not in a place to give a clear-cut guidelines on the treatment. If you just enter the rheumatic chorea treatment in the internet, you will see lot of protocols, lot of studies is there, but still there is no globally accepted protocol to treat Sydenham's chorea. Always confirm, this is the neurology chapter guidelines, confirm the etiology first, try to use valproate and haloperidol should be considered first, switched if there's no improvement after 2 to 4 weeks. Tetrabenazine and the role of steroid IVIG unproven, but may be effective. Treatment should be continued for at least 8 to 12 weeks before considering tapering, and neurorehabilitation, antibiotic prophylaxis are also important in treating this patient. Here are 3 videos and a lot of clinical clues in this, or just see the video number 1. What you are seeing, the patient is in absolutely agony, and the left side of the foot, left hand of the patient is absolutely twisting. So what is the type of movement disorder you are seeing? He is absolutely crying. Chorea will never give rise to atetosis, is not like that. Muscular pain spasm is the dystonia. So the patient is exhibiting left hemidystonia of the upper limb and the left lower limb. Now see the second video. You can see how the patient is absolutely, there is a hemiplegic sort of leg, left dystonic posture is there. And the third video, you can see the patient has an open mouth. Even the smile is a very, very peculiar smile, what is known as the vacuous smile. And this is a classical dystonic spasm, hemidystonia, and vacuous smile. And when and see the eyes of this patient. This is very, very important. Eyes give you a lot of clues. Just see that there is a brownish, yellowish, golden pigmented circular ring is there, what is known as the KF ring. We know that it is the grade 4 ring which can be seen by eyes. Otherwise, grade 1 and grade 2, you have to take the help of your ophthalmic colleagues. So serum pseudoplasmin was 16 and the 24-hour urinary copper was quite high. So this was a case of Wilson's disease, and this is again very important. Just go through the clinical parameter supported by the biochemical parameter. You can reach to the and you can see the eyes of all the relatives I have taken. You can see the, just to make the difference, and see the cornea of the brother is absolutely normal. Arcus analysis, the father is having that mother is having a normal, and these are all the, just to show you what how you can pick up the KF ring clinically. But always see that this is the grade 4, grade 3 and grade 4 KF ring can be seen easily by naked eye, and we know that this is the face of giant panda, which is a classical of MRI of the brain in cases of Wilson's disease. Another patient with lot of clinical clues in front of you, with a history that he is having a focal seizure with fever, sometimes without fever, but the convulsions were ongoing and there is no family history. Development is all normal. So if you see that, you can pick up that diagnosis is written on the face, that this is having the adenoma sebaceum is there. And if you explore the body, you can see the ash leaf macules over the trunk and the shagreen patch or the lumbosacral area. So this is a classical presentation of tuberous sclerosis, one of the very important neurocutaneous syndrome, and you can see the angiofibroma, shagreen and ash leaf. So this is a very important clinical cutaneous marker, and you can see, we will all go in more details. This is what in the figure number 1 you are seeing the classical ash leaf. This is the ash leaf, and this hypopigmented patch is the earliest cutaneous marker. Even in the newborn period, you can pick up this ash leaf. You will not get adenoma sebaceum in below 2 years of age. You will not get the shagreen below 2 years of age. This is the only cutaneous marker which is very, very important. And even if a newborn, if you see that, this patient should be a suspect for future exploration. This is another very classical angiofibroma over the butterfly area of the face. This is rarely seen below the age of 3 years, and later it is seen in 50% of the patient. You can see the shagreen. Shagreen is the piece of cloth which is kept over the horse back, the literal meaning of the shagreen. So these are the pebbled area over the shagreen, over the lumbosacral. It is also seen in other areas as well, over the sometimes over the forehead as well. So what is the relevance of age specification of the cutaneous marker in tuberous sclerosis? As I have already told you that hypopigmented macule is to the tune of 80% can be seen from birth later onwards. Then comes the angiofibroma, shagreen between 2 to 5. Puberty has seen periungual and gingival fibromas. Then cafe au lait patch can also be seen, apart from the NF1, can also be seen to the tune of 25% in tuberous sclerosis. So there is a fixed, the classical criteria to diagnose the tuberous, that is the definite tuberous TS complex, that is the 2 major features or 1 major and 2 minors. So is the probable and possible. These are the how we can pick up the tuberous sclerosis diagnostic criteria. All the cutaneous marker which we have just seen comes in the major feature, and therefore it is very important. Even if you pick up 2, ash leaf and angiofibroma, it is all done. And the minor features may be dental pate and hematoma and the cerebral migration line, gingival fibroma, like that. So these are the diagnostic criteria of tuberous sclerosis. So what is the neuroimaging findings from SANE to SEGAS? SANE is the subependymal nodule. What you are seeing is a small ring of pearl, you can say, and white matter lesion can be seen as the radial bend sign. SEGAS are the subependymal giant astrocytomas, that is more than 3 centimeters in size. Genetics, we all know that it is the gene which is responsible, the mutation of TSC1 and TSC2. It has been seen that all the patient who's having the familial recurrence having the mutation at TSC1 gene, whereas the TSC2 gene, they are seen in sporadic instances, sporadic condition, really difficult to treat. Earlier you diagnose, earlier you start the treatment, the cognition can be preserved. That is another important area of the treatment. And you can see whole of the family, and excluding the father, other mother is having a classical adenomia, but at the age of 50 years, he didn't have any convulsion. But these 3 children, out of which 2 were having the seizure, this one and this one. Another patient, absolutely classical clinical clues the patient is exhibiting. And we all know by our experience, he is exhibiting the infantile spasm. So this is, and upon examination, what is seen that he's also having the hypopigmented area over the thigh. And what are these? Let us see. So these 2, infantile spasm and this white hypopigmented spot, makes a very clinical suspicion of a particular condition which needs more. And see, the EG reveals the chaotic pattern, and the EG MRI reveals the presence of subependymolar. So this was a case of infantile spasm due to tuberous sclerosis. And this is very important, because we all know that this is the situation where treatment differs. And this is another area that any patient having infantile spasm always do the echo evaluation of the heart. And you will be surprised to know that there will be presence of cardiac rhabdomyometer to the tune of 50%. So this is the cardiac rhabdomyometer you are seeing. So always make use of your cardiologist friend to pick up all these clinical conditions. So the treatment, we all know that infantile spasm due to tuberous sclerosis, we all know that vigabatrin is very, very important. And we know that the importance, we know the drug doses, and the one was the most important is the vigabatrin causes the visual field defects and has to be taken into account with ophthalmological assistance. Here is another patient. What you are seeing here is he is exhibiting seizure activity of the right upper limb and the right lower limb. And this was the first attack. He was absolutely afebrile attack. He's a 4-month-old child. And upon examination, it was seen that he is having the port wine stain, and it was a bilateral one. So any patient who is having the port wine stain and focal seizure, you always try to think of another second important uroproteinase syndrome is the Sturge-Weber syndrome. And we all know that it can be a bilateral port wine stain, it can be unilateral port wine stain, and contralateral seizure is there. And the leptomeningeal enhancement, what we think that it should be there in the neuroimaging as it is depicted in MRI. This is the left parieto-occipital leptomeningeal. These are all the patients with port wine. You can see the right port wine stain. Even the palate is, you can see the having the stain, and the right cornea is large, the sort of megalocornea. And this is the classical CT picture in this patient having the left port wine stain. So these are all patients having the port wine stain and the focal seizure. Now, these are another important area which you routinely see that these are the seen in our neonatal follow-up patient, that this is the dimple, sacrococcygeal cleft, lipomeningocele, and hairy hair of the spinal dysraphism. These are all meningomyelocele and encephaly like that. This is another area which is very important for we practitioner to see the spinal dysraphism, because it is a very important condition which if it is ignored, it can be repeated in the next future pregnancy. That is very important for we pediatrician to deal with. And you are seeing here is the vertebral defect, urenteric cyst, spinal cord malformation, meningeal. These are all spinal occult dysraphism. You can see here as well. And any patient who is in front of you having this always try to start from the examining the head and neck, then the back, then the lower limb, and detailed neurological examination, which is very important. And investigation, plain X-ray, MRI, USG can be helpful to pick up the exact clinical anatomical defect. Always try to take the opinion of the pediatric surgeon and neurosurgeon. Another area, this is another patient with severe retrocolis. You can see this is a very severe form of neural tube defect in the anencephaly, and you can see this is the black and white is taken from the Indian pediatrics, and this was my picture of the patient, this red one. This is the anencephaly. So what is the important for the prevention? This is the CDC guidelines which has been given. It can be asked in the exam or in the viva, that 4 milligram to prevent the recurrences. This is a very beautiful picture. You can see this is the planned pregnancy time, and this you are at least 1 month preferably, and 3 months before the planned pregnancy it has to be started. Another this is another area. What you are seeing here, this is the newborn who has come in the late night. What abnormalities you are seeing? You are seeing a huge occipital encephalocele. You are also seeing there is a cleft lip, cleft palate. You are also seeing there is a post-axial polydactyly, pre-axial polydactyly is there, thumb side is there, and this is a classical presentation of Meckel-Gruber syndrome, and this is a autosomal recessive condition, and this is very important for making the counseling purpose. We have seen that one the first delivery was of Meckel-Gruber was lost, and the second issue was again with the Meckel-Gruber. So it is very important to give this patient brief of the subsequent pregnancy to come, that to antenatal care has to be at most important, and screening of to that repetition can be prevented. Another patient with lot of clinical clues, very clear-cut clues, as if somebody has painted his Muharram ke sher jaise rehte वैसे somebody has painted the back of this page, and this is what is the streaky hypopigmentation of a patient who is having recurrent seizure, developmental delay. You can see this is they are following the line of Blaschko's. These are the all embryonic line of Blaschko's, and the importance of these lines are a lot of neurocutaneous syndromes and other syndromes can follow this line, and this hypomelanosis of Ito is very, very important in this condition. So you are seeing here all the patients with unilateral streaky hypopigmentation, bilateral one. These are all patients of hypomelanosis of Ito. We all know that this is the third most common neurocutaneous disorder. No characteristic neuroimaging finding is there. There is a headache, developmental delay, and other findings as well. Another patient who is in front of you with the tuft of white hair. What are the clue? What are the things you are going to examine, and what are the things you are going to ask with this event? So it is very important that we know that there's a tuft of white hair is known as the pibaldism. So the causes of pibaldism are many, but for a neurological point of view, Waardenburg syndrome is another area of interest, and you have to see the eyes for heterochromia ready. You have to see the dystopia canthorum, that is the lateral displacement of the inner canthus, and you should ask the history of deafness and the family history. You should examine just see the mother and the grandmother, and you can see that all the three generations are having heterochromia ready, deafness and all. This is a very important condition, and the patient, how many clinical clues you can pick up in this patient. Just observe this patient. He's a 15-year-old child, and there's no family history. What you are seeing here is the hyperpigmented macules. more than 15 millimeter, and these are the nodules what you are seeing here. And so these are so these are the neurofibromas and the caffeolate patches are seen. So this makes the diagnosis of NF1. And why these are known as the caffeolate patch? This caffeolate patch is the color which is formed by adding equal amount of milk with the coffee, and the color which is formed is known as the caffeolate, and therefore it is the hyperpigmented patches is known as the caffeolate patch or CAMS. Caffeolate macules can be said, and these are the axillary freckling. If you ask the patient to show the axilla, you will see the axillary freckling. This is known as the Crowe sign, and it is seen in 30% of the cases of NF1. Now, these are the NIH consensus criteria for the clinical diagnosis. You can see the caffeolate patch. You have to count that. Always count and then take the measurement. And if the neurofibromas, they are always count that 2 or more neurofibroma, 5 or more caffeolate patch. I examine the axilla for Crowe sign. See the eyes, very important for leash nodule. Then we have a bony dysplasias, we have optic gliomas. Always ask the family history, and even the family members are unaware. When you explore it is seen that his younger brother is also having caffeolate patch, and that's make the difference of asking the and examining the brother, sisters, mother, father. This is another area. So these are the neuroimaging finding, and so now here is the patient who is just see number 1 video and number 2 video. This is the patient who is exhibiting a generalized weakness. The mother said that, Dr. Saab, these haath pair bhi nahi lata, but on seeing the face is absolutely alert. And in this particular, see, pediatric OPD is very busy. You have to see diarrhea, vomiting, fever, cough, and this is the condition when a general pediatrician refer to a doctor. These are the patient did not go to a neurologist directly. It is ultimately filtered by the pediatrician only. So always see the patient is stripped off. This is otherwise you will miss the hypotonia. This is another very important clinical clues. Alert look. Alert look is very, very important, and severe hypotonia. So these are the clinical clues. Another patient who is having alert look, you can see here traction response is poor and horizontal suspension. You can see there is a hypotonia, and they are having compromised oxygen. They require ventilation. These are all cases of spinal muscular atrophy or Wernicke-Hoffmann's disease, or also known as the type 1 SMA. So these are all the deceptive alert look in spite of severe hypotonia. Preservation of extraocular muscle is the classical clinical pearl in a case of spinal muscular atrophy. And we all know that the SMA type 1 is the Wernicke-Hoffmann's, chronic Wernicke-Hoffmann's, Kugelwall-Warlinders, and Pazio-Londi disease. These are all clinical types which we can see. And we know that these are the all causes, various causes of hypotonia. It can be asked in your exam that what are the causes are important whenever you were given a case of say you are DMD, or you can say case of SMA. These are all the important areas you have to discuss regarding nerve, muscle, neuromuscular junction, motor neuron, and CNS. And these are the investigation in a case of SMA. Straight away, SMA gene nowadays it is accessible and by MLPA, and you can see that there is a deletion in the exon 7. And this is the patient who has been diagnosed from Gangaram Hospital, and they're revealing that there is a deletion of the exon 7. Then counseling, we all know this is again very important. We have seen that one child died without diagnosis, second child has come with the similar type of condition, 2 child, and if you make the diagnosis of SMA, you have probably written the death sentence. That is another. You cannot, you are not able to make the child survive. So this is an autosomal recessive condition. 25% cases having a risk. This is the 25% having the couple risk or recurrence in the family. Prenatal diagnosis by CVS of 10 to 11 weeks gestation. Another patient with deformed skull. This is again a very important area which we should know. And here is the importance of knowing the various sutures, and trying to move your palm, who is a very sensitive. We pediatricians have a very sensitive palm over the skull, and you can pick up lot of condition, especially if your fingers are moving across the sutures and you are feeling that heaping of the suture. And is in this particular case, if the sagittal suture is heaped, and which is causing the head to elongate, what is known as the dolichocephalic head, and you can see the elongated head. And we have seen, and we have follow up this patient for 15 years. Still this having the same sort of dolichocephalic head due to the premature fusion of the this is the craniosynostosis. You can see another patient who is having the bilateral coronal suture. Just it can be picked up by rolling your finger over the scalp, and you are seeing the brachycephalic head. Brachy is the short. Brachycephalic head due to the bilateral coronal suture craniosynostosis. This is another one. If out of two two coronal suture, if one is seen, this is the bilateral coronal suture, is a syndromic one, and the PGs should be able to pick up this condition. And this is what is known as the mitten hands. All the four fingers are fused together, what is known as the mitten hands, syndactyly, even the leg you can see. So this is a classical Apert syndrome presenting with the brachycephaly. Why brachycephaly? If you will roll the finger, there is a bilateral craniosynostosis. If it is a unilateral coronal craniosynostosis, you are going to see the oblique head, and which is known as the plagiocephalic head. And a lot of syndromes can have a oblique head, that is the plagiocephalic. And if the metopic suture is craniosynostosis, you can see the triangular head, and this is the metopic craniosynostosis, triangular, what is known as the trigonocephaly. If the metopic and the sagittal continuously, it has been synostosed and leading to the tower skull, that is the acrocephalic head. So we have to differentiate whether you are dealing with a case of microcephaly or you are dealing with a case of craniosynostosis. As I have already told you that your palm is a very sensitive instrument. By make use correctly, know your importance of the palm, and you can see the shape of the skull is usually normal. In cases of microcephaly, it is abnormal, is craniosynostosis. Sutures line, you can see the uneven in this, whereas in this ridged or the heaping was there. Intracranial tension is normal. Usually the microcephaly can be increased in the craniosynostosis. That is the practical relevance of seeing the various shape and size of the skull. And if it is a craniosynostosis, try to make use of your neurosurgical colleague timely so that you can guide the family accordingly. Now, a patient who is climbing the stair, we see the video, he's climbing the stair. He is an 8-year boy. See, he's make use of the leg, and he's not able to, it seems that his proximal muscles are weakened. And this is a and complaint of, and see this is the gait of this patient. What is this gait is known as? Have you seen penguin moving similarly? This is a penguin gait, also known the Trendelenburg gait. This is a classical of proximal muscle weakness, not the DMD. The patient is of DMD, but this is classical of the proximal muscle weakness. And this is again a very important sign, which we all know that this is a classical of goer due to the proximal muscle weakness. So the clinical clues in this patient is, any patient who is having proximal muscle weakness will walk with a penguin gait, will exhibit goers, and will have hypertrophy, pseudo hypertrophy of the calf muscles. So this is, we all know that disease is exhibiting the DMD. So another very important sign which this patient is exhibiting, this is the differential hypertrophy and hypertrophy of the pectoral girdle muscles, and this is known as the pradhan sign or the valley sign. Now the Gower sign has a two component in it. The first component is that the patient, upon asked to stand up, what he's taking the help of his thigh, he just is, he's adopting on all four. He is now standing in all four. This is the component number one, and now he is now climbing off the legs to stand up. This is the floor. So these are the two very important time. This is the, and these are the causes of the go. It is not only the DMD. There are certain other conditions which can give rise to Gower positive. That is the DMD, BMD number 1. Sarcoglycanopathy is also very closely mimic DMD. We have SMA type 2, that is the 2 and 3 Kugelberg-Wallanders also give rise to Gower, and polymyositis, discitis, and JIA. All these causes are the causes of the DMD Gower sign positive. So it is very important that to note the concern of a mother. A smart mother makes often a better diagnosis than a poor doctor. See, normally a doctor pick up this condition at the age around 5 to 6 years. But if the mother is saying that he is not able to roll from spine to prone, and he is very, very concerned that he's very slow in sitting, you can be very, very alert regarding this condition. These are the two patients who is exhibiting the same sort of, but both are different clinical condition. And upon genetic analysis, it has been seen that one was DMD and one was Kugelberg-Wallanders, that is the MLPA releasing the exon 7 and B. You can see this. This is the Pradhan sign or valley sign we have seen. This is the differential hypertrophy and atrophy of the muscles. And then how to investigate? We all know that make use of MLPA deletion and duplication, and we all know that this DMD is due to, mostly it is 68% is deletion, 11% around about duplication, small mutation, and sometimes nonsense mutation can also be seen. This is a sort of approach is given in Indian pediatrics by Dr. Ratnapuri. His talk. This is the clinically suspected DMD. Do MLPA deletion, and if that deletion is or duplication is present, it is to the tune of 60 to 70%. This can be amenable to this exon 51 or etilepsaricin, especially these are the drugs can help these patients, but they're definitely a lifelong one. Here again, this patient where there is no sequencing or DMD gene C nonsense mutation, Ataluron can be make use of. These are the drugs which are available. There are some centers in India which are using this. Another patient who is in front of you having the repeated abnormal movement of the head, and he used to have frequent staring. And upon hyperventilation, this patient has been, there is a behavioral arrest. He is not responding. And this is occurring several times a day. So definitely, what is this is a classical seizure activity. Behavioral arrest is there. This is not a seizure mimic, and definitely it is a generalized sort of condition. It is not a focal convulsion. And for confirmation of this condition, always remember that if any parent is seeing that, is अभी तो खो जाता है, बात करते करते कहाँ चले जाते हैं नहीं मालूम, कहीं भी देखता रहेगा, थोड़ी देर में वापस आ जाता है. So at that time, try to make use of hyperventilation for 3 minutes. Your diagnosis will be confirmed then and there. Just you have to order EEG so as to confirm that. So this is another This is the classical 3 spike and wave of this ECG. And these are the other condition where childhood absences or behavioral arrest is seen in juvenile absence epilepsy, juvenile myoclonus epilepsy. We have epilepsy with grand mal seizure on awakening is there. So these are the all, and you have to differentiate, you have to diagnose with other condition. For example, behavioral arrest is seen in absence. It can also be seen in complex partial seizure. Daydreaming is another one which present with the behavioral arrest. Even ADHD patient can have the sort of staring spells. So these, how you can go ahead with differentiating whether you are dealing with childhood absence or not. Another patient, I have 2 to 3 cases more. No? Just I am going to finish. This is the abnormal jerking. So classically, which type of abnormal movement is it? This is the sudden shock like jerk is the myoclonus. Sudden shock like jerk is the myoclonus. So any patient, female patient, adolescent patient, early morning jerks are there. Always try to think of a juvenile myoclonic epilepsy. Try to confirm by the EEG, which will confirm that 3.5 to 6 hertz activity seeing over the frontocentral region. So all 3 types of seizure activity can be seen in JME. It can have an absence seizure. It can have a myoclonus seizure. GTCS can also occur in this patient. Diagnosis is simple, but the treatment is difficult. Another patient you are seeing, just observe. Here is the patient comes in your clinic, in your OPD, and mother is very poor. The rush is there in your clinic, and they are seeing that the child is continuously looking upwards with the retraction of the eye. So what is this condition? How you are going to take over all this mob? So ask the history of taking some drug. This is another area which is a lot of movement disorders. Any movement disorder can be there due to drug. So how will you going to explain this phenomenology? Which is having a tonic conjugated upward deviation with synergistic movement of the head upward is the oculogyric crisis. This is another very important area you are seeing here. So this is a very, very important area, and drug history is very. These are the drugs which can cause oculogyric crisis in a pediatric patient, and you have to deal with that. Another important condition due to drug is the ataxia, and here you are seeing a 5-year-old boy was given some drug. He was given Centopa. He was given at some periphery, and piperazine toxicity was there. Lot of and after stopping the drug and taking care, the patient is all right. So these are the 2 most common important cause of ataxia in children is the drug ingestion and the post-infectious cerebralitis. And these are the 2 most effective tests, that is the history and the drug screen. This is the another, just last patient, Here is a patient, he is exhibiting abnormal movements. What are these movements? Otherwise, baby is developing normal. And most of the time we have seen that this type of abnormal movements have been treated by phenobarbital, Levipil, phenytoin, but the thing is that they are not under the control. So these are the thing which is only seen in the sleep, and this is the benign neonatal sleep myoclonus. So these are all home videos. Patient has brought these home. So always try to make the patient to bring their own videos. That is very, very important. It will gives you clinical clues directly then and there. And there are few slides of rapid fire for PGs. Just you have to, what is this? You are seeing here is the left perisis of the left half of the face. Left half of the face is paretic. This is the facial pulse. What is this? You are seeing the absence of depressor angularis oris muscle on the left side. Right side, it is the normal depressor angularis muscle is depressing the angle of the mouth. So these are the 2 important conditions which you have to differentiate whether you are dealing with a case of facial palsy or a DOM absence. And DOM sense is present right from the birth, whereas the facial palsy may not always begin from the birth, but definitely, for example, in this patient, he had a facial palsy right from the birth, and he is also not able to see laterally, and this is very important condition known as the Mobius syndrome. So any facial palsy patient, you have to think all over these conditions where facial palsy can be seen. Facial palsy patient having severe pain in the ear, just examine the pinna of the ear, you will surprised to know that there are vesicle, and this is what is the Ramsay-Hunt syndrome. Here is a patient, another patient with behavioral arrest. See the importance of hyperventilation. This is a classical childhood absence epilepsy. What is this condition? Which nerve is involved? This is the right ophthalmic branch is involved. Here is the left ophthalmic branch is involved. Definitely a case of zoster. Right mandibular branch, and here is again a very important area, vesicle at the tip of the nose. This is another important condition which is known as the Sir Jonathan sign, that is the vesicle on the tip of the nose precede the development of ophthalmic because nasociliary branch having a common supply. Another patient you are seeing, just see the eyes of the patient, absolutely irritable, truncal ataxia is there, opsoclonus is very, very evident. Friend, this is a very important clinical condition, clinical clues you should not afford to miss. Always look the eyes of this patient, and diagnosis is then and there, because opsoclonus myoclonus is related to a presence of neuroblastoma, not in all cases, but definitely in few cases, and you have to explore the possibility of neuroblastoma in your clinic, and accordingly you have to refer to your neurologist colleague, because they are not going to go directly to the neurologist. It is we pediatrician that you have to filter this patient to the neurology clinic. Another patient, just on chewing, his upper eyelid is moving. What is this clinical condition? This is the classical Marcus gun phenomena. Who says it is a rare? If you try to sit in your OPD thinking that I will diagnose this condition, you will never going to miss this. And these are almost 15 patients we have picked up. All are having just on an attempt. And the best way to give the crispy item to eat, then the diagnosis will be very clear. So friends, at the end, improve your power of observation. I have said that make use all the 3 years, examining the patient, discussing with the patient, making video, making photograph. Try to be involved fully in your bedside clinic. Try to foresee the event. Most of the time we are seeing the cross-sectional area of the patient. You have to foresee the event which has not yet started to come, but you can accordingly counsel this patient. Try to make in habit of making diagnosis before investigation. Before investigation, at least on clinical ground, you should be very clear that I have made the diagnosis of this, and try to wait for the investigation so that the things are confirmed. This is the best way to go. It is not that just seeing the seizure, okay, have an MRI, okay, have an EEG. It is nowadays it has become such type of attitude, but definitely if you follow a characteristic or a systematic guidelines, you are definitely be a thorough clinician. You are not going to miss anything in future. Photo and video documentation is very, very important. This is learning disease is never complete, and presentation of disease is never final. Friends, in medicine, nobody is complete and nobody will be complete. We are a lifelong learner. Each day, even at the age of 60, 70, 80 years, sitting in the OPD, we learn a lot of things. We learn from juniors. We learn from our patient. So this is, and always try to make mistakes so that you will never make second mistake. So visual clues are real your asset. So with this important message, I conclude my talk, and I hand over this floor to our Dr. Shalabh. Thank you so much, and probably I have I thought that PGs will be, it will be helpful for PGs to be more clinically oriented and more clinically focused rather than reading for MRI and reading for EEG and all. This is what I have to say.
Excellent presentation by Dr. ANOOP VERMA, sir. It's always nice to hear you. I still remember the presentation given by you at the National Neuropedicon at Srinagar. So after seeing that, I diagnosed one case of hemihyperplasia and hemihyperpigmentation yesterday only in my clinic. So thank you, sir, for your excellent.
Thank you. Thanks.
So over to Rashmi ma'am. Any other question from the house?
Yes, Dr. ANOOP, this is Dr. Sanjay Niranjan from Lucknow. In infancy, there is quite an overlap whom to refer between pediatric surgeon or neurosurgeon. Neurosurgeon says that pediatric surgeon takes more time in operating hydrocephalus, which should be done early. And
pediatric surgeons are as good as the neurosurgeon. And pediatric surgeons are always closely related with the pediatric nursing homes and pediatric facility. Whereas the neurosurgeons, they have, if he is a only pediatric neurosurgeon, then it is okay. Otherwise, they have less experience than the pediatric surgeon. They know the science and biology of the better of a newborn better than the neurosurgeon.
Please unmute Dr. Rashmi Kumar. Madam has asked to be. In the meantime, one more question and one compliment. Mother versus doctor. Often mothers are worried right from the newborn period, and we dismiss the skin signs as birthmark hoga, and later many of them turn out to be tuberous sclerosis or something. So you are very right that always listen to the mother. Do not dismiss the things. And Dr. Pradhan have been my senior at KGMU. Later, yes, he was 2 or 3 years senior. He taught me as a PG in my undergraduate days. So, so I wish you come up with ANOOP VERMA sign in neurology. Yes, it is well deserved. And thank you over to Rashmi Kumar, madam.
Hello, sorry, I was somehow muted and also my video was turned off. So I was wondering how I should communicate. But anyway,
it so happens that you were made the co-host, but when you join after means leaving, then that co-host status gone. So you have to make you again that co-host. That's why.
Okay, so now I think it's fantastic. It's been a wonderful and a fantastic talk with such a wonderful collection of videos and cases, you know, completely worked up cases with all the images and, you know, follow-ups and everything. I think it's just fantastic, Dr. Verma. And so I think you have really lived up to our expectations with this presentation. And I must, you know, one thing I'd like to say is that pediatric neurology is really one branch which is very amenable to the use of technology, in which technology actually helps us a lot. Because nowadays, the smartphones, I mean, they're really a boon. You can just take a video and you can click a picture, and the videos, you can take serial videos. And not only take serial videos, you can send them to people. You know, my patients send me videos of seizures. They send me videos of abnormal movements. So it's such a boon, and you know, you can have the complete follow-up of your patient, even without the patient having to travel all the way to you. So this is wonderful. We just had, I mean, I remember last about 2-3 years back, we had a thesis on movement disorders in children. And this is what we were doing. It became so convenient that you can ask the patient to send you the video after 15 days of treatment, you know, so you can follow up your patient like that. So it's all very nice, very, very nice and informative talk, Dr. ANOOP Verma. Thank you so much.
Thank you.
Dr. Sethi sir, you like
anybody else in the audience?
Dr. Sethi sir, would you like to add something?
Sir, please unmute yourself.
अनम्यूट है सर, अनम्यूट है सर,
आप म्यूटेड है सर,
म्यूटेड है सर.
Sir, unmute yourself, sir.
Sethi sir, you are not audible, sir.
You're still unmuted actually.
Host can host.
नहीं, वो सर तो co-host है, तो वो तो कर सकते हैं.
अच्छा.
Sir, unmute yourself, sir. सर कुछ
सर जो माइक है रेड बटन सर उसको क्लिक कर दीजिए सर. जो म्यूट बटन है आइकन है नीचे लेफ्ट साइड में. नहीं हो रहा सर. ट्रीटमेंट्स.
Sir, Vegabatin is a drug of choice in infantile spasm due to tuberous sclerosis. And tuberous sclerosis is one of the cause of infantile spasm.
Right.
हाँ, हो गया.
Sorry,
Sir.
so sorry. Actually, I'm not very conversant with all this technology nowadays, and every time I find it difficult to do it. And I've been,
Doesn't matter.
I must say hello to Dr. RASHMI, Dr.
Hello,
ANOOP,
namaskar, doctor.
Namaskar, and to ANOOP also. Dr. VERMA was there, and he delivered his talk, and it was such a beautiful talk. This is really I've learned, and the lovely videos. In fact, I was sitting next to him, and I asked him कि आपने खुद बनाया कि किसी से बनवाए हैं? तो कहने लगे मैंने खुद बनवाया. I was surprised, that he has been doing the cases and doing the videos and then presenting it, and God, good gracious Lord, it is absolutely fantastic, really fantastic. And we'll be listening to you again in our conference. All of you are invited. Dr. Shalab, of course, is there, invited to the conference in Jhansi on 29th and 30th, and we'll all see you there. We'll welcome you and we'll give you a rousing reception.
Thank you, sir.
So
Thank you, sir.
it is really great, and thank you, Stella, for making me a part of this particular. In fact, I just also want to tell you that by some reason of whatever it is, I am also the vice president of this association.
Sir. Vice President.
Yeah. So I'm very happy that I'm here today. Thank you so much. Thank you. And of course, he was with us a couple of days back. The present president, Sanjay. We met, a couple of days back, and you were so nice to have him in our place, Jhansi. Thank you so much.
Thank you, sir. Sir, I request Dr. Sanjay Niranjan sir to please conclude the session.
Sure. Excellent. I would say, as Dr. Anoop has said in the beginning, that the neurology you learn from the patient's bedside, and he has taken us to 17 bedside cases and say dozen spotters, and in a very right and appropriate speed, and with all the visuals. So it was really, I would say, as you are seeing in the comments, it was a great learning experience. And as they say, we are learning from the patients. I would say pediatricians learn neurology from pediatric neurologists. Like Dr. Rashmi Kumar and Dr. Anup Kumar, the way they teach, nobody can. So pediatric neurologist is very patience keeping, teaching, I would say, also, apart from the cases. So thank you very much, Dr. Anup Verma. Thank you, madam.
Yes,
Dr. Rashmi Kumar, madam, my teachers,
you.
Dr. Rohit Sethi, sir, Dr. Shalab, Dr. Anup Kumar. So all are welcome to State Pedicon Jhansi. All the audience, I would say, you are most welcome to Jhansi. It is a conference being held at Orcha, and this fort of Jhansi was built by King of Orcha. Very few people know. And Queen of Jhansi was born in Varanasi, and she died at the age of 23 fighting at Gwalior. We have a lot more memories. So welcome to the UP Pedicon. We also have a neurology session there. And thank you. Over to Shalab.
Thank you, sir. Thank you all, sir. Thank you, Dr. Anoop.
Thank
Thank you,
you.
ma'am. Rashmi, ma'am. Thank you, Dr. Anoop Kumar, and thank you, sir. Chetty, sir.
Thank you.
Thank you all.
Thank you, everyone.